Welcome to Infection and Immunity, Evidence Explained, a Doherty Institute podcast. I'm Rebecca Elliott. Well, after a long hiatus, we are back. We're so excited to be bringing you the latest news and information on all things infectious diseases from the Doherty Institute and our collaborators. In the early days of the podcast, we were very much in the thick of the COVID-19 pandemic. Now we are living with COVID and there's plenty of other infectious diseases that need our attention. So moving forward, we'll certainly still cover COVID from time to time, but it will be mixed in with plenty of other content. But on today's episode, I have a very important question for my guest, Professor Sharon Lewin, Director of the Doherty Institute. Is the COVID-19 pandemic officially over? And what are the experts discussing behind the scenes to prepare us for the next pandemic? Sharon is a world-leading infectious diseases expert. As an infectious diseases physician and basic scientist, her laboratory focuses on basic, translational and clinical research aimed at finding a cure for HIV and understanding the interaction between HIV and the hepatitis B virus. Among her many additional hats, she is the inaugural director of the Cumming Global Centre for Pandemic Therapeutics and the president of the International AIDS Society. Professor Sharon Lewin, welcome back to Infection and Immunity Evidence Explained.
It's great to be back after a little break, but wonderful to be back.
Excellent. Well, when we last spoke on this podcast, which was back in January 2022, the Omicron variant of SARS-CoV-2, the virus that causes COVID-19, was absolutely rampant. Does that feel like a lifetime ago to you?
It does indeed. January 2022 was the beginning of Omicron, but it was the beginning of having a very big impact, real impact on our lives. And it was a very chaotic time. And everyone will remember that, running out of antigen tests and high numbers of infections, hospitalisation, impacts on food chain. And it was very chaotic. And it's extraordinary to think where we're sitting right now. That's, of course, not saying that COVID has gone away.
Yeah, we really just sort of opened up, didn't we? It was just like, let this thing rip almost, I guess. Was that the right thing to do at that time?
Very hard to examine events, what we call in medicine the retrospectoscope. There were things that perhaps we could have done differently. It's important to remember that by the end of 2021, there was huge fatigue of what was happening in Australia over 2 years with limitations. We thought we had a much milder variant, which we did. We had 95% of the population vaccinated with the first and second vaccines. So it was a reasonable way to do it. I think what we underestimated at that time, and this will, of course, should and will all be formally reviewed to make sure we do things differently next time, was probably testing. When the numbers were so high, and yet we needed to test to know how to manage infections and isolation and et cetera, even though we weren't quarantining contacts at that time. It was the testing that was really had a big impact, not being able to access testing. So yes, every country had to make that jump. I've just been in China and heard about their jump in opening up in October 2022, so much, much later, and their experience in trying to manage Omicron. Absolutely impossible to manage it public health-wise. And then you've got to question, why are you doing this for an infection that's got much, much, much lower morbidity? So it was a very difficult time. There's no doubt about that. There were some unexpected issues around the massive increase of infections. And I think we can always do things better. But Australia needed to open up. And with the world vaccinated, COVID is a very, very different beast now.
Well, so now we are very much living with COVID-19. So is the pandemic over?
Well, the pandemic as a public health emergency, I think, is over. The COVID is not over. It's now an endemic infection that we'll never get rid of. We still continue to see SARS-CoV-2 evolve, and yet we have not seen evolution towards worsening disease or increasing hospitalisation. I think the big focus now should be on people at risk of severe disease. For immunosuppressed people, COVID remains a very, very big problem, and we still need better tools to help immunosuppressed people who generally don't make as good an antibody response to vaccination. We used to have a second shield for those people, which was antibodies, long-lived antibodies that you give as an infusion and can protect people that can't make their own antibodies. Though with the current variants, we have no antibodies available, although there are some very interesting antibodies in development. We do have antivirals, of course, which continue to play a very important role. And for the elderly, it still remains a big issue. So, and then, of course, the issues of long COVID and repeated infections and what that means for your risk of long COVID. So there's lots of things we have to still keep studying, understanding, collecting data, continuing and to reinforce a good public health message. But the messages are very different now to what they were in January 2022.
And I'm assuming we're right in the way that we're living when, there are virtually no restrictions, and that's the right thing to do now in this stage of the pandemic or endemic, as you said before.
Absolutely, no question about that. Yeah.
Good to hear. Now, the Commonwealth Government recently announced an inquiry into the COVID-19 response. How important is something like this?
I think it's incredibly important that we take an objective look at what happened and how we might do things differently, what were the gaps and where the investments should be going forward. This is being done in many countries now, some countries at a very formal level with the Royal Commission, which is happening in the UK. Many people are critical of that because they think it will take literally years, and so therefore you're not going to have an outcome for a while. We've, of course, already had a review in Australia which was commissioned by 3 major philanthropic agencies, and that was, I think, very informative. I think the most important thing is not a point and blame game. That's not going to help anyone. All of us were dealing with the unknown, and I would love to see a focus on practical solutions. I was recently in France and heard about what they've done on their review. And interestingly, they had a review in the midst of COVID. I think it was towards the middle of 2021 where they invited external people to review. And what struck me was that they asked international experts to review what was happening in France. And I think that international perspective would be really important. I think the Commission has largely got Australians on it, all very eminent and capable of doing a great job. But I think we've got to move from a very Australian view of what we did to how we compared with the rest of the world, not by looking passively at numbers in Australia and the rest of the world, but really learning from the rest of the world's experience. And so hopefully there'll be some international input here as well.
At the beginning of the pandemic and right through the thick of it, the Doherty Institute played a key role. What are you most proud of?
Wow. Well, looking back over the last 3 years, I am, first of all, most proud of how the Institute worked together. I think we were very collaborative, cohesive, shared a lot of information in those early times where there was so much uncertainty. I've been travelling a lot over the last 12 months, and I have delved into the details of many, many different countries' response to COVID, which I find very interesting. And I think what we did well in Australia was a very quick and early response. So the events of January and February 2020 cannot be underestimated. That early response put us on a different trajectory to many other countries. And in the wash-up, the excess mortality in Australia, and by excess mortality I mean predictions, we can accurately predict the numbers of deaths in the future based on the number of deaths in the past. And then we look at how many additional deaths happened from what we predicted. And it's this very hard endpoint of measuring impact because, of course, COVID itself led to many deaths from COVID, but COVID also had an impact on many other aspects of our health system that would have led to increased deaths, such as late diagnoses of cancer, etc. So when you look at the excess mortality in Australia, we did very, very well. About a tenth of that of the US, 10% of the total deaths. That is a huge amount, and about a fifth of what was reported for the UK. And how did that happen? There's lots and lots of complex reasons why, but the early events of January and February 2020 were very, very important. And Doherty played a major role at that time, which of course was helping establish testing around the country, the isolation of the virus, the earliest descriptions of the immune response. And in February 2020, we were also lucky enough to receive our first philanthropic grants from A2 Milk and the Jack Ma Foundation. And that gave us resources such as the ability to open an animal PC3 facility, support some of our researchers developing a vaccine and building cohorts. And those events in that chaotic time of February 2020 led to an incredible amount of work and contributions in the diagnostic space, in genomics, in modelling, of course, understanding pathogenesis, developing a vaccine, developing new approaches to therapeutics. It's really very impressive what we were able to achieve.
It's certainly been an incredible ride, and obviously our work in COVID-19 continues. Now, you were one of the many experts who attended the Global Virus Network's meeting in Monaco in October to examine pandemic preparedness and current threats. For our listeners not familiar with the Global Virus Network, it's a coalition comprised of eminent human and animal virologists from 71 centres of excellence in 40 countries, of which the Doherty Institute is one. Now, at this meeting, two areas highlighted that need to be strengthened when it comes to pandemic preparedness were antivirals and diagnostics and surveillance. So what was said about antivirals?
Well, antivirals were a disappointing part of the COVID response. We eventually got good antivirals, which was in December 2021, 2 years after the onset of the pandemic. And by antivirals, I mean oral antivirals. We, of course, had antibodies quite quickly, but antibodies need to be infused and there was resistance to antibodies. In contrast, we got a vaccine much quicker, and so there's a lot of analysis about why that happened. And actually, this was a lot of the thinking behind the establishment of the Cumming Global Centre for Pandemic Therapeutics, which was that about the total investment in novel technologies for developing antivirals compared to vaccines is about 10% of that total investment. And the approaches that we use for novel antivirals takes a long time. This is something called high throughput drug screening, and it takes time. But what we do need is a sort of stockpile of antivirals that work across multiple families, the key culprits that we predict will cause a pandemic. But we also have to be ready for the unexpected. So a recent example, Mpox. Mpox is a pox virus. It was on no one's list for a pandemic. We experienced an outbreak of Mpox in the middle of 2022 that travelled around the world, affected many, many people, affected a distinct subgroup, of course, largely men who have sex with men. But we had done very little on Mpox. So we can, for pandemic preparedness, we can think of the big 3 or 4 that we're likely to see, but we can also get caught by surprise. And so therefore, we don't have the antiviral in the stockpile. Can we develop a novel antiviral at speed? And there was huge support for that. And it was very interesting to hear of all the different efforts happening around the world. I had the fantastic opportunity to tell that group about the Cumming Global Centre for Pandemic Therapeutics. We are planning to spend 30% of those funds internationally. We've just launched a foundation grant program for external investigators, and the members of GVN, the Global Virology Network, are likely to be applicants, I hope, for that program. Every major infectious disease is predominantly dealt with or controlled by vaccination. Much cheaper, much easier to get population coverage. However, vaccines aren't perfect. People still get breakthrough infections, as we have seen with COVID. For some infectious diseases, you may never develop a vaccine, as we've seen with HIV, hepatitis C. Many, many decades of investigation and we don't have a preventative vaccine. And highly potent antivirals can not only prevent one from getting sick, as we see currently with Paxlovid, but can also prevent you getting infected in the early stages. Now that we don't have antivirals, oral antivirals that do that for COVID. The antibodies did that to some extent, but in HIV, it's amazing that HIV has been completely managed with antivirals for treatment and antivirals for prevention. So absolutely vaccination is the sort of underpinning way we deal with infectious diseases, but we have to be prepared for these situations that are inevitable.
Okay, so we've touched on antivirals. Now, what was said at this meeting on diagnostics and surveillance?
Well, there's a lot of discussion about better diagnostics for both animals and humans, surveillance to detect emerging infectious diseases. This is really quite difficult because how much testing do you do and how do you really know which viruses are ultimately going to jump species? But important to do that. There was a discussion around sharing information. That was obviously really important in the early days of COVID, and a very interesting presentation on the role of wastewater surveillance, which we have, of course, been doing in Australia. We've been doing it for many years in Australia, in fact, here at the Doherty for looking at polio in wastewater. But some very interesting information from Texas about how wastewater surveillance for multiple viruses, not just COVID, can predict outbreaks. So I think we're going to see a really great contribution of other modes of surveillance. Another idea from some of the investigators that were present was to conduct surveillance in airports or airports where there's high traffic hubs, airport hubs like London or Miami, Singapore were some that were raised. And that may also be a good way of detecting new viruses. I think point of care testing in COVID was very interesting. It came at the right time. Of course, didn't have enough diagnostic tests as we talked about in early 2022, but now people are so familiar with that approach. We've got to take that learning into other infectious diseases as well.
Yeah, and is that something that we might see in the future, is those point of care testing for other viruses?
Oh, definitely. There's some tests available that can detect both influenza and COVID and potentially even RSV. We've had point of care testing for HIV for many years, but it's never really been widely used in Australia. Many of the restrictions on its use are now lifted. So I think we'll be seeing an explosion of point of care tests, which is great.
Absolutely. Now, you mentioned earlier that you were recently in China and you were the moderator of a panel discussion between Fudan University and Doherty Institute infectious diseases experts in Shanghai, which looked at lessons learned in China and Australia from viral pandemics to bolster future pandemic responses. What were some of those key takeaways?
Well, 11 members of the Doherty Institute went to Fudan University to visit a group of expert virologists with whom we have had a relationship for over 14 years before the Doherty even existed. This relationship started by Stephen Loccanini with Zhenghong Yuan, who are both experts in hepatitis B. Zhenghong is still at Fudan. Stephen, unfortunately, has retired, but the legacy lives on of that relationship. And every 2 years, Fudan visits us, or we have visited Fudan. So this was the first trip post-COVID. In fact, it was the first delegation we heard to visit Fudan. So that was very nice that we were part of that. And as you mentioned, we did have a panel discussion on the responses in China and Australia. Now, the group that we work with in Fudan are largely laboratory-based virologists. They're not public health physicians or policymakers. So we didn't really discuss policy. We discussed laboratory capabilities that are needed for a pandemic response. And some of those were around technologies for growing viruses. Some of it was around generating potential mutant viruses. That sounds a bit scary, but by doing that, it can predict what might happen. We talked about workforce, that you can't create an expert workforce in virology overnight. We talked about antiviral drug discovery. So we really talked about capabilities in virology, not on policy response. Policy response in China was probably a slightly trickier conversation.
Now, when SARS-CoV-2 came along, it was very much taken by surprise because we thought that the next pandemic might be a flu, for example. Do we have any idea what the next pandemic might be?
Well, most agencies around the world have lists of pathogens of pandemic potential. They're all very similar, but there's some minor differences. The WHO has a list which they're currently revising. The NIH have a list. CEPI, the Coalition of Epidemic Preparedness Innovation, have a list. And they have about 8 to 10 families of viruses that are most likely to cause a pandemic. The ones we worry most about are pathogens that are transmitted by the respiratory route, because that's a very easy way to spread quickly. And the top two there are, of course, influenza and coronaviruses. But there's another group of viruses called paramyxoviruses. Measles is one of them. Another, which is only been seen in Australia, Hendra virus, and also Nipah virus. And there's currently an outbreak of Nipah virus in India. So those are the top three families that can be spread by respiratory route. But there are others that can result in a pandemic. Of course, vector-borne viruses spread by mosquitoes, changing distribution of mosquitoes with climate change is something of importance. And then we can get pandemics that are spread by means we'd never even imagined, which was, of course, HIV, which is spread sexually, as was Mpox, as many other bloodborne viruses. So we have a list of rare ones that have pandemic potential, or more common ones that have pandemic potential. I think in Australia we should also be very cognizant of some unique infectious diseases that we just have here, that the rest of the world are not working on. And if the rest of the world aren't working on it, we have an obligation to be working on it. And they include largely vector-borne diseases such as Murray Valley encephalitis, where we had an outbreak earlier this year. Very high mortality rate, but very difficult to spread. But what we worry about with viruses that are difficult to spread is some mutation that makes it easy for them to spread. Ross River virus is another one. So we in Australia need to think carefully about viruses that are of high relevance to us in Australia and high relevance in the region.
So are we better prepared for the next pandemic?
I think we are better prepared. There's a lot of people that like to say, we're no better prepared, this is a disaster. I think we are better prepared, but we've still got a lot more work to do. And part of that preparedness is around awareness and what a pandemic is and the consequences of it. The role of closing borders, not just to stop a virus getting in, but to stop a virus getting out. That was something that was very, very foreign to us in 2020. And we shouldn't underestimate the level of how our thinking has changed, and therefore using that tool as a tool for implementation. The understanding and investment in vaccine technologies, the fact that we have mRNA, which can be rapidly adapted to a new vaccine, the increased awareness around therapeutics, the familiarity of point-of-care diagnostics to the population. Having said all that, there are still many gaps to fill. There needs to be better coordination around the world, and there needs to still be significant investment. Investing in pandemic preparedness is a bit like investing in your military capabilities, that you hope to never use them, but you need to have that capability to respond in an emergency. And what we're seeing around the world is the governments really quickly want to forget about the pandemic and move on, hope it's not going to ever happen again, but it will still need significant investment.
Yep, and we are very much there working on this. Professor Sharon Lewin, thank you so much for joining me today.
Pleasure. Thanks, Rebecca.
And thanks to all of you for listening to Infection and Immunity Evidence Explained, a Doherty Institute podcast. We'll be back in your ears every fortnight on a Friday. And if there is a specific topic you would like us to cover, please get in touch with us by emailing doherty-media@unimelb.edu.au. That's doherty-media@unimelb.edu.au. If you've enjoyed our podcast, please rate and review on your favourite podcasting app and subscribe if you haven't already. The Doherty Institute is a joint venture between the University of Melbourne and the Royal Melbourne Hospital. See you next time.